Moving on to our approach to the patient with unconsciousness or altered mental status. Here's Jordan Moskoff on TV approaching his patient who comes in with altered mental status or unconsciousness. The first thing you want to think when a patient comes in who's unresponsive or unconscious is, do I get to intubate? That's definitely a possibility. So check for a gag. If you have pooling of secretions, then that airway is yours. You go. If not, you're yellow. You need to move on to your ABCs. Just a reminder of the quick rapid apnea assessment. Takes just a few seconds. When you get a patient who comes in unconscious and you're not sure if they're breathing, position the head, look, listen, and feel. If you have no obvious breathing, go ahead and bag to look for obstruction and check the gag as we told you. Then check the pulse, take action as needed. In this patient, we had a yellow airway. So we moved on, completed the ABCs, breathing and circulation. The patient was breathing and the circulation was adequate. So we move on, acknowledging the patient had no pooling of secretions and no emergent need for intubation. So we check for reversible causes. This is a critical point to the assessment of patients who have altered mental status or unconsciousness. Don't forget the don'ts. D is for dextrose, O is for oxygen, N is for Narcan, T is for thiamine, although I've truly never seen someone reverse their altered mental status emergently with thiamine, but it works for my mnemonic. And S is for shock, the patients with VT or VFib. These are the reversible causes of in unresponsive patients. These are critical. I can't tell you how many times people have not listened to these lectures and gone on to do this SIM course and get caught up with patients with really low glucoses who are unconscious, and they go right past it and try to work up the patient. This is a huge mistake, and it's so stupid. You can't let this happen. Imagine a 50-year-old patient came in with focal neurologic deficits and altered mental status, and you got them rushed right into the scanner, straight into the scanner. They had a normal plain CT, but then you had a long delay because there was an IV problem. They couldn't finish the CTAs. Ultimately, the patient comes back in about 45 minutes. At that point, the AccuCheck is done, and it's found to be 30. I bet that guy wished he went to a hospital where they focused on reversible causes. Perhaps he will be so impaired he won't know to be upset with you. How about this one? A 45-year-old obese female presents unconscious with minimal to no gag and limited respiratory drive. RSI and multiple failed attempts at intubation, one of which breaks her front teeth. And then ultimately she aspirated when the LMA was attempted. An astute medical student identifies pinpoint pupils. Narcan is given, and she rips out the tube. She is furious about her teeth and later needs to be reintubated because of her refractory hypoxia due to her massive aspiration. Could that have been avoided? All you would have had to do is check for reversible causes. This is essential. One more time. A 55-year-old male found unresponsive with minimal gag and agonal respirations. RSI and multiple attempts at intubation, 10 minutes from presentation. Post-intubation assessment, 000. The monitor shows VTAC and then VFib. If you check for that VTAC early before you went on to intubate the patient, perhaps they would have had a better outcome. My goal when I'm managing patients is to manage all of my patients in such a way that it will never be true that if they had gone to any other random ED, they would have had a better chance of a good outcome than what happened with me. Imagine prolonged hypoglycemia, possibly resulting in permanent neurologic impairment. Prolonged hypoxia and limited perfusion in the second case, possible permanent neurologic impairment. Prolonged cerebral hypoperfusion, possible permanent neurologic impairment. All easily avoided by a little forethought and focus on reversible causes. It's easy to miss in the moment, difficult to forgive in retrospect. So don't forget the don'ts. All right, now do I get to intubate? All right, hold your horses. We got one more consideration before you make that move. Can you get any more information from your patient before you intubate, such as history, allergies, risk of coagulopathy, or a neural exam for lateralizing signs or evidence of trauma? This is actually very important. When you're assessing a patient who's got severe altered mental status or is unconscious, you need to immediately look for evidence of trauma in the head, lateralizing signs or findings on neurologic exam, or any reason to think that the patient would have a coagulopathy, either by history or by evidence of liver failure, for instance. If the patient has any of these three things, they absolutely have priority into the CT scanner. Nothing else is done. They need to go very, very quickly to the CT scan so you can get things done. If they don't have these three things, then there's a real possibility that the patient has a medical or toxicologic problem that's causing their mental status change. The priority in those cases is EKG and a medical or /tox workup. Now, that's not to say that the CT is not done promptly. All I'm saying is if they don't have lateralizing signs, evidence of trauma, or clear coagulopathy, you don't need to immediately send them to the scanner. You don't want to rush the tricyclic overdose over to the CT without access and an EKG if you can help it, right? By the same token, you don't want to spend undue time getting in the EKG and the lab sent on altered patients with hemophilia. When time matters, critical thinking and individualization of the patient care can be life-saving. So take a second, think it through. Remember that this is a branch point that may change how you use your resources. The risk assessment for patients with altered mental status or unconsciousness is first, pooling of secretions, then identifying reversible causes, vital signs, evidence of head trauma, pupils, lateralizing neural exam, and then past medical history. You can do one-stop shopping here with a pen light and a tongue blade. Get to the head of the bed. Check the gag. While you're there, check the pupils. Check for evidence of head trauma. Try the finger behind the ears Vulcan maneuver to see if you can wake the patient up. Then crack the stick. Scrape the palms. Scrape the soles of the feet. See if the patient withdraws equally on both sides. Facial grimacing should also be watched. And then you're done. Question answered. To do a complete workup here, you'll probably need a CT scan, EKG, pulse ox, lab tests, including VBG for lactic acid, especially in patients who you think might have seizures, CMP, CBC, PT-PTT, tox screens, and drug levels, and a chest x-ray, especially if you think there's a possibility that the patient aspirated. After you've completed this, you'll be well down the path of sorting out what caused your patient's altered mental status and stabilizing them for admission. Thanks for hanging in there. See you next time.